So we are going to cover radiology section tonight. So the 70,000 series. Okay. Let's just jump straight into our first question. So our first question, we're going to work this one as a coding from scratch. Okay. So we're just going to ignore the multiple choice for just a couple of minutes. We're going to act like we don't have those down there, but we have a 40-year-old female that's scheduled for a routine screening baseline bilateral mammogram with computer aided detection or CAD. So let's look at it from a CPT standpoint first. Okay. What procedure or what is it that we are doing or performing that we want to look up in the alphabetic index of the CPT manual? So what's our main term that you want to use? Mammogram. Yep. Perfect. Okay. So we'll go to mammogram. And then once we get to mammogram, underneath you have a mammography entry as well, right? So you have a mammogram entry that says 77065 to 77067, right? But then underneath that, you have a mammography entry, and that gives us a couple other options. Okay. So in those couple other options, we should have an option for screening mammography. Do you guys see that? So what codes does it give us for screening mammography that we want to go look at? 77067. Yep. So let's go look at our CPT code 77067. Make sure that our code description matches. Okay. So our code description for 77067 is a screening mammography, bilateral, two-view study of each breast, including computer-aided detection or CAD when performed. So that is what we have here, right? Our screening baseline bilateral mammogram with our computer-aided detection or CAD. So our 77067 is our correct CPT code, right? So let's think about this now from an ICD-10 standpoint, right? Because whenever we bill a claim, we have to have a code for the reason for the encounter. Okay. Is there anything wrong with the patient that is signaling that we need to do a screening mammogram? Or is this just, again, a routine mammogram that they're just coming in and that's the reason for the encounter is that screen? Okay. Yep. So for our ICD-10, okay, again, we're looking at this from a coding from scratch standpoint because we want to make sure that we not only know how to test, but we want to make sure that you guys know how to work it in the real world. Okay. So our main term for ICD-10 is going to be screening, right? Because that's what they're coming in for is a screening. So underneath screening, what are we screening for? We're doing the mammogram, but what does the mammogram actually screen to detect or rule out? So yes, we are screening the breast, but what are we scanning and screening the breast for? Cancer. Yep. So what's the medical term for cancer? Yep, our neoplasm. Perfect. So underneath screening, we'll go to neoplasm, and then we'll go to our anatomic location, which is the breast. And then because this is a routine mammogram and there's not any signs or symptoms that are triggering that screening, okay? So at that point, it's going to be a screening for a malignant neoplasm of the breast, and it's going to be our routine screening. So what ICD-10 code are we going to choose for that? Yep. So Dawn, your Z12.39, that is going to be for an unknown reason for it versus making sure that you're going all the way down for that screening, right? You see that now? Okay. So we just want to make sure that our Z12.31 matches code description wise, because we never want to code directly from the alphabetic index because typos and just things happen, right? So our routine screening and the Z12.31 is for encounter for screening mammogram for malignant neoplasm of the breast. So there we have our Z12.31, which indicates that our correct answer and choice is going to be the Z or is going to be letter C. Does everybody see that? Anybody disagree? Anybody have any questions about that one?
I do have one question.
Okay.
So I do see that Z12.31 says a first listed code, or maybe the screening is listed as first, even when there is CPD codes. CPD codes are always first, and then ICD-10.
Where, I'm just curious, where are you seeing that at? Because I'm not seeing that in my ICD-10 book.
I was looking at these codes earlier before, and like guidelines. It says Z12 official guidelines. So my question is, when the main code, like if you go like the main Z12, the official guideline goes to all the codes under Z12.
Oh, okay. Okay. I see it underneath the category Z12 where it says screening the IC21C5.
Mm-hmm.
Okay. So what was your question on that one again? Can you repeat your
So my
question?
question is, when they says these guidelines under Z12, so these guidelines is considered for all the codes under Z12.11, Z12.12, 13, whatever. So is it good for all codes for Z12?
Yes. Whenever you have a guideline or a code also note or an includes or excludes note directly underneath your category, so that Z12, it will
Mhm.
apply to everything in that Z12 category.
Okay. So now my next question is, so the screening codes are the first listed codes. Am I correct?
Usually, when you have a screening code, those will typically be the only code on the claim because when you have a screening, you typically aren't going unless you have a history code or something along those lines. But your reason for your encounter, if you don't have a specific guideline telling you what your sequencing should be, so in this instance, we don't have a guideline telling us this code should be first, this code should be second, this code should be third, right? In
Mm-hmm.
the absence of a guideline indicating sequencing, then at that point, then the reason for the encounter should be your first listed code. So in this case, it would be the routine screening. The Z12.31 is our first listed. And then if they have a family history, then those would be listed second, right? Because they're not coming in because of the family history. They're coming in for the screening particularly. They're just having the screening because of the family history.
Right. So now my other question is, if they have multiple CPD codes and if they have few the ICD-10 codes, so always the CPD codes are always first and then ICD-10?
For testing purposes, yes. When you
Oh,
have a claim form and you're submitting it to your insurance payer, they're going to be in separate areas. So, like, it's not going to matter how they're listed because in the real world, you're not going to have them listed out just on a single line, right? You're going to
Right.
have different screens in your EMR system that's going to have your assessment, which is your conditions, and then you're going to have one for like the procedure codes. Okay.
Mm-hmm.
So for testing purposes, yes, your CPT codes, if you have CPT codes and ICD-10 codes, then your CPT codes are always going to be listed first.
Okay. Well, thank you.
You're welcome. Absolutely. Okay. Any other questions? Okay. So let's go on to number two. We have a 56-year-old patient who's been admitted that requires a tunneled CV catheter insertion. The physician uses an ultrasound guidance to perform the insertion. And then the physician documented vessel patency and the permanent recordings are in the patient's record. So what CPT codes are we going to use for this service? Let's look at this one from a process of elimination standpoint. Okay. So we are coding for our radiology service. Okay. But because the procedure has a radiology component of it, we also still have to report whatever the service is. Okay. So if the physician is doing both the surgery or this cardiovascular procedure, and then we also have to report the radiology service as well. Okay. So that might be why you see in your radiology or the 70,000 series on your exam, you might have questions that include another surgery section component. Okay. So from a testing perspective, we're going to do process of elimination. Okay. So we're going to, the way that I would do it is I have two options that have 76937, right? And then my other two options are different codes. So I'm going to go to 76937 because I'm either going to confirm that that is a correct code or I'm going to rule it out and say it should be one of the other two radiology codes. So 76937 is ultrasound guidance for vascular access, requiring ultrasound evaluation of potential access sites, documentation of selected vessel patency, concurrent real-time ultrasound visualization of vascular needle entry with permanent recording and reporting. And then we know that this is an add-on code, so we still have to have our primary procedure, right? So does everyone think that the 76937 is our appropriate code? Does anybody think it should be another code, or does everybody agree that the 76937 is appropriate so we can rule out C and D? Yes. Yep. Because it's for the ultrasound guidance is specifically for that vascular access, which is going to be that tunneled CV catheter insertion, right? We also documented the vessel patency, and then those permanent recordings are going to be there. So correct. Our 76937 is our correct code for our radiology component. So now we need to go look at the 36556 and the 36558 and determine which one we should use for the actual insertion of that tunneled CV catheter. Okay. So Dawn thinks it should be the 36558. Luke says it should be the 36556. So let's look at the difference between the two. Okay. So our 36556 is going to be for an insertion of a non-tunneled centrally inserted central venous catheter, and then for ages 5 years or older. 36558 is indicating that it's for a tunneled centrally inserted central venous catheter. So our procedure that we did is for a tunneled CV catheter. So it should be the 36558. Yep. So 365, oh, I crossed out the wrong thing. No, I didn't. Just kidding. 36558 is our correct code for the catheter insertion because it's for a tunneled CV catheter versus a non-tunneled. Okay. So our option should be letter B. Okay. Any questions on why we should choose the 36556 versus why we should choose the 36558 versus the 36536? My numbers are getting away from me tonight. Any questions on that? Okay. The modifier. Okay, yes. So let's go back to the 76937. Okay, let's look at our code description here. So our code description is basically telling us that it's a global component, right? There's not anything indicating that they're only doing interpretation and report, or supervision, and interpretation or anything like along those lines, right? So because they have been admitted, then this is indicating that they were admitted into a hospital, right? So if the physician is not employed by the hospital, because we're only reporting for the physician services, right? At this point, the physician is only responsible for that professional component of the service, right? Our TC modifier, which is our technical component, that TC portion is going to be what the facility has to have overhead wise to run that ultrasound machine. The payment on the ultrasound machine itself, the electricity that it requires to power it up, the gel that they have to use. Also, it could be the ultrasound tech. It could be the room, the oxygen, the lights in the room, the gown that they have to wear, right? All of that's going to fall underneath the technical component that is there, that basically is made up of anything that it takes to perform that service, not the physician's service of looking at the ultrasound and interpreting it as that ultrasound is guiding in that catheter. Does that make sense, Sandy? So professional components is going to be the professional opinion by that provider to interpret the images as they're putting it in. And then your technical component is going to be anything that it takes to operate that ultrasound machine. Since the physician is not employed by the hospital, then he's only billing for his service. And then the facility, the hospital, will bill out for the technical component of that service. Okay. Good question. I know TCs and 26s will get a little confusing. Okay. Let's look at number 3. So a parent brings her child into the emergency department. She thinks that she swallowed a small toy figure. A radiology exam from nose to rectum is performed, and the foreign body is not located. So let's look at this from a coding from scratch standpoint. Okay. What service did we perform? Yep, the radiology exam. So what is a better term for a radiologic exam? An x-ray. Yep. So we'll go to x-ray in the alphabetic index. Underneath x-ray, what portion of the body did we do the x-ray on? Well, it wasn't necessarily a total body, right? Because they didn't do the whole body. They didn't do the arms. They didn't do the legs. They did nose to rectum. So if we look underneath x-ray at nose to rectum, and then they've got a single entry down there for foreign body. Okay. So our CPT code is the 76010. So let's go look and see and make sure that that's our correct code. So 76010, our code description for that is going to be radiologic exam from nose to rectum for a foreign body, single view on a child. Does everybody see that that's why we would use the 76010 versus using individual x-rays for each individual portion of the body? Especially because they're saying that a radiologic exam, so they only did one single x-ray. So if we were to code these out separately, we would get paid for services that weren't performed, and we would get paid for 5 x-rays, right? When we only did a single one. Okay. Any questions on that one? Okay. Number 4, a 40-year-old female has cholelithiasis with chronic cholecystitis. She is in the ambulatory surgical center to have a laparoscopic cholecystectomy. A dye was injected to perform an intraoperative cholangiogram. The surgeon who performed the procedure included a separate report with his interpretation of the cholangiogram that indicated that there was normal free flow into the duodenum with no evidence of filling defects and no stones or strictures are seen. So what CPT codes are we going to report for the professional services of the surgeon? Okay. So we know that 74300 is our correct code, right? Because it's in all 4 options. We have 2 options with a 26 and 2 options without, right? So let's go look at the 74300. See what our code description states and see if we should use the 26 for the professional component or if we should not use the 26 because it's only a professional component code. So our 74300, that code description is for a cholangiography or pancreatography, intraoperative radiological supervision and interpretation. So do you think that we should use a 26 modifier with the code, or should we not use a 26 modifier? Okay, I've got a couple answers in the chat. So a couple people say, yes, we should use it. So yes, we should actually use the 26 modifier here. Because again, we are only performing the supervision and interpretation. And since it says in there intraoperative, right, it's telling us that that's the full global package. So we should use the 74300 with a 26. Okay. So again, we are only coding for the professional services. So we should make sure that we report only the professional services and not a global component so that we don't get paid for the technical when we don't own the equipment. Does that make sense? Okay. So now all we have to do is just rule out between 47563 and 47562. Yes. So Sylvia, you're right. So that keyword of the fact that it is in the ambulatory surgical center, that's telling us another component that we know that the physician did not own the equipment. Yep. So I am flipping to 47563 and 47562. Okay. So the difference between our 47562 and our 47563 is that 47562 is for a cholecystectomy only, And then the 47563 is for a cholecystectomy and a cholangiography. So did we perform both of them, or did we only do a single component? Yep, we did both. We have the cholecystectomy here, and it was done laparoscopically. And then they also did the interpretation of the cholangiogram here. So, yep, we would use our 47563. So our option would be letter C. Okay. Any questions on that one? Okay.
How
Look
do
for
we know
which
if,
other codes.
well, just in general, like what are the things that make 26 be taken into consideration for anything?
Your place of treatment that it's done. Okay. So if it's done at the doctor's office, that doctor's office more than likely owns the equipment. If it's done in a facility, whether it be an ambulatory surgical center, a day surgery center, an inpatient hospital, an ER, things along those lines, the doctor's not going to own the equipment at that point. So that should be your number one thing to tell you that you more than likely need to use a 26.
So a 26 is not used if it's in a hospital.
No, the 26 would be used if it's in a hospital.
Like where would it not be used? Sorry,
No, you're
I'm
fine.
not
It
mad.
would
I just
not be used if the physician owns the equipment. So more than likely in their office.
like if it's in a doctor's office.
Yes. Yes.
But I mean, like what would be the other alternatives where it could be used besides a doctor's office, besides a hospital?
Well, you more than likely, um, you would not use well, okay, hang on. Let me make sure I'm saying this right because I think we're saying two different things. So a hospital, okay, so the only time that you want to use a 26 is if the physician does not own the equipment. Okay. So if they are at a hospital, then the hospital owns the equipment, right? So
So
that's
that's when I
whenever
wouldn't
you
use a
would want to use a
26.
26.
Yeah. Could you maybe private message me this later because I don't want to take up the most of the time with the group.
Yeah, yeah. And then I've got some YouTube videos too that'll help explain it. So I'll send you those as well.
Okay, great. Thank you.
Okay, you're welcome. Okay. Any other questions that you guys can think of? Okay. So let's look at number 5. So number 5 is a patient with hydronephrosis, has a left nephrostomy, and they have agreed to a pyelography or an IVP to rule out a right renal obstruction. The patient was placed prone on the x-ray table after 1 hour of IV infusion of contrast. The contrast flowed from the left and right renal pelvis down to the ureters into the bladder, where a Foley catheter was positioned. The IVP showed no obstruction or abnormalities in the left urinary tract aside from the left hydronephrosis of the pelvis. The right kidney and the ureter showed no obstruction. Bladder within normal limit, or the bladder appeared within normal limits. So what CPT code are we going to report for the radiological service? Okay. So what service did we perform? Yes. So the IVP. Yep. So our IVP, okay, that is going to be an I think it's an IV pyelography, I think is what the IV stands for. So the intravenous. So the main term that we're going to look up, okay? So what an IVP is it's going to be a type of radiologic exam, okay? So if we have a radiologic exam, that's going to be an X-ray, right? So it's basically going to be an X-ray with contrast. So we'll go to X-ray. Underneath X-ray, we'll go to with contrast. And then underneath with contrast, we'll go to the urinary tract because that's what we were doing the X-ray on, right? We were looking at the ureters, we were looking at the renal pelvis, we were looking at the bladder. Okay, so that's going to be just our urinary tract. So underneath urinary tract, is there anything underneath urinary tract that tells us we should choose a certain option? So I want to hear you guys think. Is there anything that's listed underneath urinary tract that we should use? Well, so Sylvia, underneath urinary tract in the index, there's not a catheter option. Okay. So what I'm saying is underneath urinary tract, now those indented options that we have there. Yes. So Disha, you're right. So you would go to urography and then intravenous. Okay. Does that make sense? Because we're doing a exam again of the urinary tract, which is the urography. And then we would go to intravenous because we did it with the IV contrast. And then it's 7-4-400. Everybody see that? Okay. So let's go to 7-4-400. Make sure that our code description matches. Again, because we never want to code directly from the alphabetic index because the typos are possible. So 7-4-400 is a urography or a pyelography, intravenous, with or without KUB, and then with or without tomography. So does everybody agree that our 7-4-400 should be our code? Yep. Okay. And then we'll use a 26 because where's my keyword here? Well, in this scenario, I probably wouldn't have taken a 26 on this because there's not anything indicating that they're in a facility or a hospital or anything. But in the real, like in testing, because you have a 26 on everything, then obviously we need a 26. I don't know. So Disha, I'm not sure that I would even say for the radiological services, that's indicating that we should only do the professional component because the radiological services could be anything, right? They're not saying the professional component of the radiological services. They're just saying the radiological services in general. Okay, Luke, what's your question?
Just say, I was just saying raise his hand means that I agree with you.
Okay. Okay. No, you're good. You're
Sorry
good.
about that.
No, you're fine. I just
Sorry.
wanted to make sure you didn't have a question. I didn't want to skip over if you had a question.
Oh no, not at all. I should have clarified what I meant, so I was at fault there. Sorry about that.
Oh, you are good. You are good. Dawn, I think you're looking at the next question. You're going ahead on us. You're fine. You're totally fine. Okay. So let's go ahead and jump to number 6. Okay. So a 25-year-old female in her last trimester of her pregnancy comes into her obstetrician's office for a fetal biophysical profile, also known as a BPP. An ultrasound is used to first monitor the fetus's movements, showing 3 movements of the legs and arms, which are normal. There's 2 breathing movements lasting 30 seconds, which are normal. A non-stress test or an NST of 30 minutes showed that the heartbeat was at 120 beats per minute that increased with movement, which is normal or reactive. Arms and legs were flexed with the fetus's head on its chest, opening and closing of a hand. 2 pockets of amniotic fluid at 3 centimeters were seen in the uterine cavity, which is normal. And then your biophysical profile scored 9 out of 10 points, which is normal or reassuring. So what code should we report by the obstetrician? Okay. So for this one, how would you start to do this from scratch? What procedure did we perform? The BPP. Yep. Yep. So let's go look at BPP. Let's see if it's underneath that acronym, or if we need to actually look up the full spelling of it. I don't remember if it is or not. Yeah, I don't see it under BPP. So let's look at it from a spelling out. So we're going to look at biophysical profile or fetal biophysical profile. Let's do fetal because it's a little bit more specific. So looking for fetal biophysical profile, you have 2 codes. Does everybody see those 2 codes? Is everybody in the index underneath the fetal biophysical profile?
Sorry, what page number is that? I couldn't see biophysical.
If you have the 2024 CPT manual, it's 1,161. And it's in the 3rd column. And it's your 3rd blue text. So Sylvia, I don't know if it's under, or no, sorry. Who said that? Hang on. So Milvia. I don't know that you would be able to get to it under ultrasound and then obstetrical. Let me look. Okay. Yeah, you can get to it from there. You would just have additional codes that you would have to sift through. And then Sandy went to fetal testing and then ultrasound and biophysical profile. Yes. So there are multiple ways. Yep. There's multiple ways that you can find things in your index. Okay. But again, that's why you always want to make sure that you confirm your codes in the tabular or up in the actual code set just to make sure that you have the correct code. So yes, Sylvia, your 76818 and 76819, if you are looking at fetal biophysical profile or fetal testing ultrasound biophysical profile. So it takes you to those 2 codes specifically. So let's look at 76818 and 76819. So Sylvia, give me just a second. Let's look at the 76818 and the 76819, and I'll let you know why we're not choosing 59020. So give me just a second, and let's look at the 76818 and 76819. So your 76818 is for your fetal biophysical profile, or that BPP, with non-stress testing. And then 76819 is without non-stress testing. So did we perform a non-stress test as well as that BPP? Yep, we did. We had that non-stress test of 30 minutes. So we did not only the BPP, but we also included that non-stress test. So our code selection should be the 76818. So Sylvia, let me go back and look at your 59020 and see why we're not using that code. Give me just a second. Let me get up there. So your 59020, were you meaning to put 59025 instead of 59020? Yeah. Yeah. So the 59025 is just the fetal non-stress test that did not have that fetal biophysical profile done as well. So that's why you have to make sure that both of those components. So you would not want to report the 59025 as well as the 76818 because you would get paid for that fetal non-stress test twice. Okay. You also would not want to code 76819 with the 59025 because you have a code that bundles that BPP and the non-stress test together. Does that make sense? So if we have a code that has a bundle, we should never report the two components separately. Okay, perfect. Okay. Any other questions or any thoughts on that one? Okay. So let's go to number 7. So we have a 65-year-old female that has a 2.5 centimeter by 2 centimeter non-small cell lung cancer in her right upper lobe. The tumor is inoperable due to severe respiratory conditions, and she is receiving stereotactic body radiation therapy today under imaging guidance. Beams arranged in 8 fields will deliver 25 grays per fraction for 4 fractions. So what CPT and ICD-10 codes should we report? So how do you guys want to approach this one? Any thoughts? Let's look at this from a testing standpoint. So if we see something like this that has a lot of words that we're not completely sure of, right? Then let's try to make it less intimidating. Okay. So Dawn, which chart are you talking about? No, did you change your mind?
Yeah, I was thinking of something else. I thought there was a chart.
No, you're fine. You're
Never
fine. I was
mind.
going to say, I don't remember there being a chart, but that doesn't mean
Yeah,
that my
just
brain
ignore.
remembers everything. You're fine.
Yeah, just ignore me. My mind goes to other places in the book.
Were you thinking because of the cancer? Were you thinking of the table of neoplasms? Is that what you were thinking of?
I thought there was a chart. I thought there
Okay.
was some kind of.
You're fine. You're totally
Just
fine.
ignore me.
So the way that I would do it, okay, I have 2 codes that are close to each other for the CPT. I have 77371 and 77373 together, right? They're not the exact code, but they're pretty close to each other. So that's where I would go. So I would go to the 77371 and the 77373. So our 77371 is going to be for radiation treatment delivery, stereotactic radiosurgery, complete course of treatment of cranial lesions consisting of 1 session, and then it's a multi-source cobalt 60 based. So 77371 is indicating that it's on a cranial lesion, right? Which is in our brain, or at least on the skull, right? So I would not use 77371 by that one keyword for our anatomic location. 77373 is going to be stereotactic body radiation therapy, treatment delivery per fraction to 1 or more lesions, including imaging guidance, and the entire course not to exceed 5 fractions. So we had stereotactic body radiation therapy, right? So our code description is that stereotactic body radiation therapy. We had 4 fractions. Does everybody know what a fraction is? So your fraction is going to be your treatment. Okay. So how many times they actually deliver that radiation therapy into the body, how many sessions or treatments that they have. Okay. So it's one or more lesions. We only have a single lesion, right? Because we only have a 2.5 centimeter by 2 centimeter non-small cell lung cancer. And then it has including imaging guidance. So it's under imaging guidance. So we're not going to report that part separately. Okay. And again, it's our 5 fractions, or it's our 4 fractions that do not exceed 5 fractions. Okay. Does everybody see the 77373? Okay. And let's actually look at 77435. Okay. I want you to see that if you would have gone to 77435 instead of the 77373. Okay. So if you would have read 77435 first, it sounds very similar to our 77373. However, there's some differences. So 77435 indicates that it's for stereotactic body radiation therapy, but it's for treatment management. Yes, Sandy. Where the 77373 is for the treatment delivery. Okay. So that management is going to be where they are doing an exam. They're determining whether or not those fractions are correct, right? So the dosage of the radiation is correct. So it's very, very similar. You just have one word difference between 77373 and 77435. Treatment delivery versus treatment management. Okay, does everybody see that? And then your 77431 is the same thing, but it's for radiation therapy. And again, it's your management. Okay, so make sure that you're seeing the treatment delivery versus the treatment management. Now, if you get confused, okay, in this case, we do have ICD-10 codes that we can help rule out as well. Okay. In 77435, you have the same ICD-10 codes. They're just in different sequencing. Okay. So if you remember, if we have an ICD-10 guideline that tells us if our encounter is solely for the administration of chemo, radiation therapy, or immunotherapy, then our CPT or our ICD-10 code, in this case, it's the Z51.0 because it's radiation therapy. That should be sequenced first. Okay. If our encounter is solely for the treatment and the administration of that radiation therapy, then the radiation therapy encounter for code, the Z code, should be listed first. And then the malignancy should be listed second. Okay. So if you couldn't decide between the 77435 and the 77373, then you can always use your ICD-10 codes to figure out your correct code. Okay. Any questions on that one? Yeah, Sandy, that's a good way to put it. Your encounter for is, it trumps your illness only if that's the reason for the encounter. If they're coming in for an evaluation of the illness, then your illness would be your first listed. But in this scenario, because your encounter for is the reason for the encounter and you didn't have anything else going on for them to evaluate, then, yep.
I have a question. So in this question, how can we figure out treatment management and treatment delivery? What is the difference?
Treatment management, like I said, in your guidelines, your treatment management is when they're doing an examination of the patient to determine whether or not your dosages are correct and whether or not it's working. Where your treatment delivery is they are only just there to deliver the radiation therapy. So kind of think of it in the aspect of delivery, again, is only delivering that, where your management is you're managing something, trying to determine if it's appropriate.
I haven't been writing notes down. Am I doomed?
No, no, you're totally fine.
Yeah, I just trying to multitask, like while watching this is hard.
Yeah, yeah, no, you're totally fine. What you can do, Luke, is in the Discord group, there's a link to that Google Drive. And then if you want to, you can always print out those questions, the same questions that we're going over now. Those are usually available by Sunday or Monday of the week. So you can always print those out and then actually go through and make highlights and notes on those questions as we're going through them, if that might help you too. So you're not having to
But the
just.
thing is, I don't have a printer.
Okay.
So I haven't been writing the notes down as we've been talking, just because, I just hope that this isn't going to bite me later on.
Well, you can always go back and re-listen to it again too and make notes the second time around. So if you want to just pay attention while we're going through them, and then when the recording is available either later on tonight or tomorrow on YouTube, then you can go back through and listen to it and pause it and take your notes as you need to. And then once you finish taking your notes, unpause it and replay it.
Okay, yeah, because sometimes trying to take notes along with the video, because I try to write things word for word a lot, because it's just because it feels like everything that is coming out of your mouth is absolutely important.
Yeah, no, you can definitely, like I said, as you re-listen to the video, you can pause it and write your note however you want to write it, or rewind it and play it multiple times if you need to make sure that you get your notes correct. But yeah, that's always an option. So you don't always have, I know that some people take notes as we do it. Some people will go back and re-listen to it again and take notes. That's why we have the recordings available for it.
Well, thanks again.
Yeah, absolutely. All right. Anything else that you guys want to chat about before we're done? Okay. So again, the questions 8, 9, and 10, you guys can walk through them on your own. On the Google Drive, your answers are down at the bottom, along with the rationales. Okay. So you guys can work through those. If you have any questions on those whenever you get to them, then don't hesitate to put those questions in the Discord channel. And then just as a reminder, you also have a fill in the blank option, right? So that if you want to work on it from more of a real world perspective versus prepping for test prep, then that option is available for you there as well. Okay. So there's multiple ways that you can do your questions. If you do them all multiple choice, and then you're like, hey, I think I've got this, I'm going to go down and do it now from scratch, that's going to kind of test your retention of the knowledge as well. Okay. All right, guys. Well, I am going to hop off of here. If you have any questions, don't hesitate to reach out. And like I said, you can shoot me a message on Facebook. You can shoot me a message in the Discord group, or you can just post it in the Discord group. If I'm not available, then if somebody else can answer that, then they can absolutely jump in. But if you guys have anything, then don't hesitate to reach out. If not, then I will chat with everybody on Wednesday of next week.
I have a quick question before you end. Can I do now?
Yeah.
Okay, so for the practice exams from AAPC, all those medical terminology questions, if we just study over those 6 exams, we should be good for medical terminology?
I don't want to say yes, because you never know if they're going to throw in a question that is not on there. That's why it's kind of important to just have a general understanding of med term and anatomy, so that, if you know what a certain root word means, you can break down, right? Where if you know that the suffix itis is for inflammation, you can break down usually whatever questions med term wise, as long as you have that general foundation of your medical terminology.
Okay, thank you.
And also, I just wanted to say is that I needed to be here tonight. It was really encouraging, because the last couple days since taking the practice exams have been really stressful and discouraging.
Well, good. I'm glad that it encouraged you and it kind of relit that fire. Another thing that I did want to
Like,
mention, and kind of touching on Puny's question that she had about medterm and anatomy. I am in the process of getting all of my medterm and anatomy and pathology recordings from previous classes that I've done. I'm getting those uploaded into YouTube. So you will have a good refresher of videos out there for medical terminology, anatomy, and pathology. Um, YouTube has been very slow in uploading anything that I have tried to upload today. So it unfortunately is taking me a lot longer to get them uploaded. But they will be released over the next couple of days and maybe even the next week or so. But hopefully by the end of next week, I will get all of the videos for all of the body systems, medical terminology, pathology, and anatomy out there for you guys. So if that's an area that you struggle in, those recordings will be out there slowly but surely in the next couple of days, if not like a week or two. Okay. So I just wanted
and
to kind of put
also,
that out there.
I sent you this message. I sent you a private message on Facebook, and this is the same thing. So basically, I want to make sure don't take practice tests until I finish going through my study guide.
Yeah. Yeah. Because we want to make sure
Yeah,
that you have
and
a general comprehension of the material before you get in there and start doing those again.
and also, how much should I read out of my study guide? This was said in my private message, so then that I sent to you. Like, how much should I read per day? Because I don't want to take too long, but at the same time, I don't want to go too slow,
Well,
too
it all
fast.
depends on the rate that you can read and the rate that you can absorb it. So there's going to be some chapters that you feel like you might be able to absorb it and understand it a little bit better, and a little bit quicker. But then there's definitely going to be some chapters that you are going to feel like it's going to take you multiple times of reading it to comprehend it. Cardiology in particular. um,
Yeah,
so
and
just keep that in mind. So I don't necessarily want to say do so many chapters a day or do so many chapters a week or so many pages, because it all is going to depend on how you absorb and comprehend that material.
yeah, because I know I need to be ready. I just don't want to keep putting my exam on hold, and also I'm just have the concerns about the fill in the blanks.
Yeah, yeah. Yeah, let's talk about that a little bit more privately. Just that way we can maybe try to set up like more of a customized plan for you. But yeah, that definitely is something that is just going to depend on, how quickly you're absorbing it and comprehending it for each chapter.
Okay, yeah,
Okay.
maybe when you see my Facebook message, you could private message me, and maybe we could try to schedule a time to meet.
Yeah, absolutely.
Yeah, best times for me are after 3:30 Monday through Friday because that's when I get off of work.
Okay. Yeah, that's usually the time that works best for me. So yeah, we'll definitely get some conversations going about it. Okay.
Thank you, Tiffany. You are incredible. That's all I gotta
You're
say.
welcome. Thank you. You all have a good evening. Okay.
Good night.
Thank you.
All right, good night.